Here is the question given. The clinical scenario is 16 years old man with history of acute chest pain. Acute chest pain. ECG here are normal. ECG is not normal. ECG shows ST depression and T wave inversion. Okay, and cardiac biomarkers is given normal. Okay, cardiac enzyme normal. Mostly we are measuring trop T and troponin I. Okay, and I is more sensitive. Okay, then we are saying here what first we will diagnosis here would be acute coronary syndrome. Acute coronary syndrome, and most specifically because ECG changes plus a cardiac enzyme, we can say this is a unstable angina. Unstable angina. Okay, unstable angina. For this, let's see what's the drugs which are given. So we have to see what are the management. Okay, oxygen can be given. Aspirin, yes, can be given for unstable. Ticagrelor, yes. Metoprolol, what? Metoprolol is a beta blocker, and beta blocker we are not giving. It is drug of choice for stable angina, not unstable angina. Without further evaluation we cannot give meto, so this is the wrong answer. Oxygen, sublingual nitroglycerin, antiplatelet, streptomycin. Okay, oxygen can be given. Sublingual nitroglycerin we are giving for chronic cases, stable angina, not unstable angina. So this is also not answer. Antiplatelet can be given. Streptokinase is a thrombolytic agent. We are not doing thrombolysis in unstable angina. So this is also wrong option. Antiplatelet and lower molecular. Yes, antiplatelet and lower molecular weight heparin. It decreases the plaque formation and reduces the risk of myocardial infarction. So this can be given. Okay. Oxygen can be given. Sublingual nitroglycerin we are not giving. Digoxin is not given in acute coronary syndrome. So answer here is antiplatelet, low molecular weight, subcutaneous. Okay. Okay. Here is the question. First, we will see about BLS. BLS. If you are a bystander, first see, check for scene safety. Check for scene safety. Call help. For if you are giving for medical professional, they will be giving 100 to 120 per minute chest compression. Chest compression. Uh, Depth of chest compression should be 2 inches. 2 inches or 5 centimeter. 2 inches or 5 centimeter. Uh, uh, CPR ratio should be 13:2 for adult, 1 or 2 rescuers. Okay. For a child, infant, adolescent, if there is two rescuer, ratio should be 15 gem 2. If one rescuer, you can give same as adult. Okay. How then we are seeing some advanced ACL, somewhat of, not all the first, like in any emergency, we are following a protocol of A, B, C, D: airway, breathing, circulation, and disability. Okay. If we are seeing there is a pulseless tachycardia or ventricular fibrillation, so we can give cardiac defibrillation. Cardiac defibrillation by 150 to 200 joule by phasic wave. Then we can do chest compression for 2 minutes. We are doing this. Then chest compression for 2 minutes without checking pulse. Without checking pulse. And we are doing then cardiac defibrillation. Okay, cardiac defib 150 200 joule biphasic wave 2 minutes. Then check for pulse and ECG to be normal or palpable. Or if pulseless electrocardial activity or asystole, never give shock in pulseless electrocardial or asystolic. Okay. We are doing normally chest compression. Can be given adrenaline. If adrenaline doesn't work, atropine can be given. Atropine. Uh, Central line. After giving this, central line can be secure. Okay. Which one of the following is non-shockable rhythm in respect to AD? Okay. First, we will see shockable rhythm. Shockable rhythm are pulseless tachycardia and ventricular fibrillation. And non-shockable rhythm are non-shockable rhythm. First, pulseless electrocardial activity, or you can say it as a asystole. Okay. So we have seen the option monomorphic ventricular tachycardia. Yes, it is a tachycardia is a shockable. Polymorphic ventricular tachycardia is a shockable. Ventricular fibrillation, yes, it is a shockable wave. What is pulseless electrocardia? Non-shockable rhythm. So correct answer is pulseless electrocardial activity. Here is first clinical scenario. Clinical scenario. 15-year-old man. 15 years old man. Complaint of breathlessness or palpitation. Breathlessness, palpitation, and acute chest pain. Okay, acute chest pain. We have done ECG. ECG shows ST elevation in anterior leads. So what is the next investigation? So here we see the case of acute coronary syndrome. It might be MI or it might be unstable angina. Question mark. So for identifying that, we are doing cardiac enzymes, and most commonly cardiac enzyme we measure is TROP-T and troponin I, and troponin I is more sensitive than TROP-T. So we'll just see the option first. 15-year-old physician, okay, emergency acute chest pain, we have seen everything. Okay, so which are the investigation we are doing? Echocardiography just takes too much time. We are not doing this. We are not doing TMT. We are not 24-hour Holter morning is done for unconsciousness, or we are not doing it. The right answer is cardiac troponin T and cardiac troponin I. Okay, and that is the right answer.